I'm Steve Estus. Dan Lee, we thought we'd do a little tag team here, asking questions. Stump the experts? No. This is to learn from the experts. And so we'll work through as many of these questions as we can. We'll try to direct the questions to whoever we feel might be the best person to answer that particular question. I'll start with this question. Can an overload of stress cause more memory loss? And how can you determine normal memory loss? So it's a memory question, and an overload of stress, how does that cause memory loss? Anybody who feels like Lisa?
I think that's right up your alley. Okay.
So the question is, can an overload of stress? So in order to know if something is an actual cause, you have to do, a randomized clinical trial, right? Where you have some people who have stress, some people who don't, and then you see what the outcome is. That's impossible to do in real life, right? Because we all have stress. You can't take away someone's stress. You can probably do it in animals maybe, but not in humans. So the research that I talked about was from observational studies where we just quantify how much stress someone has and then we see how it impacts their memory over time. And so I think a little bit of stress is good for people in general because it motivates you to move and to, make things happen. But too much stress is bad, and it can affect all kinds of systems in our body, including our brain health. So I think the short answer is that yes, an overload of stress can affect your memory. Does it cause memory loss? We don't know that for sure. We know that it plays a part, but to know if it's a causal factor, you have to be able to do a randomized clinical trial.
Can I say something just quick? So I suspect some of you are caregivers, maybe just taking a random guess out there. And one of the things, there we go. One of the things that I see in my patients and the caregivers are under a lot of stress. And sometimes that stress causes them to have issues with their thinking. And so one of the things I say to caregivers is to take care of yourself. The biggest gift you can give a patient is to take care of yourself so you can be there for them. So I just wanted to add that because I think if you are a caregiver, you're going to experience stress.
All right. There's a lot of great questions in here. So we're not going to get to all of them. So I apologize. We apologize if we don't get to your question. But one of the ones that was noticeable is have we seen an increase in Alzheimer's disease or other forms of dementia since COVID? And if so, what do you think that is attributed to?
I think I'll comment on that. Having been here in Kentucky throughout the COVID pandemic with all of you, and we still see COVID ongoing nowadays. There has been a big impact, not just in terms of memory, but on the aging population. Age actually was the #1 risk factor for mortality, for COVID taking someone's life. And when we look at the numbers of lives lost during the COVID pandemic, overwhelmingly, it was the senior population affected, such that nationally, we see the average lifespan has lost 3 or more years over the last 4 years because of those deaths. We're still trying to understand. We have long COVID in some where they may have memory problems that persist. We're trying to understand the biological basis for that. It has been too soon for us to draw any conclusions or parallels into Alzheimer risk. But like all things, we want to stay as healthy as possible. So please, as we enter flu season and COVID season, there are some that cannot take vaccinations because of prior reactions or allergies. and that's acceptable. But as many of us as possible that are tolerant of those vaccines, I encourage you. I went last week, COVID over here, flu over here. I couldn't feed myself for a day. But I contribute that to my first step towards a healthy diet, as Dr. Barnes was talking about earlier.
Good. Any other comments?
The NIH has sponsored a very large study to look at this. And so there will be more information, but as Dr. Jicha pointed out, it's going to be a bit.
There are quite a few questions on sleep, and there are the questions like, does it matter? Do prescription drugs, how do those impact your sleep? Are those a good idea? Is having especially vivid dreams, is that a relevant marker for sleep? And how can you gauge how good your sleep is? All right, and so maybe Dr. Macauley would start at least.
Yeah, so there's actually a lot of clinical trials ongoing right now that are targeting actually the sleep centers in your brain to see if you take them and restore healthy sleep, whether you can actually change the progression of those plaques and tangles. And so we know that, when you're awake and you're doing things that you make more amyloid beta and tau, you go to sleep, you actually clear those proteins and stop making them. So there's the idea that, going to sleep is good, but not all sleep is great sleep. And so there's a lot of different mechanisms that are ongoing at the moment to try and figure out what that balance is. And it might depend upon where you are on the Alzheimer's continuum. I think if you have vivid dreams during REM, that means that you're going through that cycle, actually. And so you're going through the early stages of light sleep, into that deep restorative sleep, and then into REM. So I would think that that's a good thing, right? So we all know if we've had a short night of sleep or really restless sleep, you don't get into that deep restorative sleep. So dreaming is good. And that's like, again, when you have that memory consolidation as well.
Any other comments? Okay.
So I'd just like to make a comment, and I think Dr. DeCarli commented on this earlier, that, we're talking about sleep apnea, how a little bit of alcohol and or sedatives. We do have to be careful as we age that many of the sleep medicines are sedatives of sorts. And so finding the right balance, it's really important. If you're having trouble with your sleep, please, if you're in our program, talk to us when you come in for your evaluation. Call us and we'll find a time. Ask your primary care doctor their recommendations. But I think always, get yourself educated on the treatments that you may be seeking or that may be prescribed to you, because you really want to know when your doctor hands you a sleeping pill, what is this? What's it going to do? And sometimes if the dose is too high, maybe it's going to cause sleep apnea. And yes, you'll sleep for those numbers of hours, but you're going to experience negative health consequences. If you're on the right sleep medicine, if you need one at the right dose, it should not cause negative side effects. So this is really tricky, and I advise everybody to really speak with their doctor about sleeping aids. Over-the-counter sleeping aids are usually not recommended for people over the age of 65. They contain high levels of antihistamines, Benadryl, that have anticholinergic effects and can actually cause temporary memory problems. And if you take them every day, that temporary problem could end up being a chronic problem. So whatever you're taking, whatever you're doing, please run it by your doctor and ask the right questions.
Follow up on the one thing that a lot of people do, we've talked about it today, is have sleep apnea. And a CPAP is actually a great way to normalize your sleep and improve your sleep. And there are clinical studies that have gone on that show that they do lower some of the amyloid and tau in your cerebral spinal fluid. So that's something where you're not using a pharmacologic intervention, but that can actually improve sleep and might actually impact the AD progression, but studies are ongoing. The other thing I think was asked is that there's a lot of technology now where you can monitor your sleep, and just being mindful of this, keeping a consistent sleep time. Like I have an Aura ring, and so every night it kind of says, "Hey, Shannon, go to sleep. Stop looking at your phone or writing a grant." And then it'll tell me my type of sleep, and I was absolutely amazed to see what types of things were impacting my sleep. Exercising too late in the day my heart rate wasn't lowering, or sadly, alcohol like really is not good for sleep. I was very sad about that glass of wine. But so there is, I mean, your Apple Watches, Fitbits, all of this, actually, the technology is coming where, again, you can take ownership and see how some of those sleep changes are happening just with devices we have on our arms at this point.
Okay, this next question is about hearing loss. Any connection between hearing loss and the potential of getting dementia? How significant is the effect of hearing loss and the level of cognitive function?
So I have congenital hearing loss, and you probably saw maybe you didn't see it, but hearing loss has been associated with increased risk for dementia. And I'm a little anxious about that, to be honest with you. We don't know why. I do know that hearing loss does one very striking thing, and that is it causes social isolation. And so it's really important, if you have trouble with hearing or you have ringing in your ears, that you get evaluated, because if it does lead to withdrawing, I think that may be why it increases the risk. And so I would just say we don't quite yet understand the biology of hearing loss, why it may be associated, but it does. It's one of the modifiable risk factors. I didn't talk about it, but it was on one of my slides.
I'll just say, I heard at an Alzheimer's conference recently that there's a study looking at hearing aids. So that's why he's saying it's modifiable. If you have hearing loss, the hearing aid, using your hearing aids, because my mother does not use her hearing aids, can actually help, with your risk. So I encourage you, if you do have hearing loss, please use your hearing aids. It helps.
And someone who's put off getting hearing aids for a long time, hearing aids have gone through a revolution. Okay, so the quality of hearing aids that my dad had and the ones that the next time you'll see me, I'll probably have on, are completely different. They are so much better, and they actually work. So, and they can be tuned to your exact problem, whereas in the past they were just just amplifiers. So if you're hesitant to get evaluated for hearing aids, trust me, I was that person. And that it's a new world, and you might find them actually pleasingly helpful.
I wanted to make just a brief comment because we're one of the few centers that have published on the biology, Alzheimer's pathology and hearing loss. Just a few years ago in the Journal of Otolaryngology, working with the ENT department at UK. And this is also a plug for thinking about donating your brain, because we were able to look at folks with reported hearing loss. We knew whether or not they were using hearing aids, and if they were using hearing aids, if their hearing aids were effective. And we looked at only those folks that had donated their brain tissue when they had passed away. And we could clearly see that hearing loss is a risk factor for memory loss. But interestingly, when we looked at the brain, for the same degree of memory loss, people with hearing loss had fewer plaques and tangles. That does not mean that it's protective against plaques and tangles. That means at much lower levels of plaques and tangles, you will exhibit the symptoms of Alzheimer's disease if your hearing is not effectively taken care of. And that's really important. That's what we call cognitive reserve. So boost your cognitive reserve. get a hearing aid, make sure that it's effective to really boost your cognitive reserve.
Great. So we had several questions about brain donations. Are brain donations required to be in these studies? Are brain donations a primary barrier to recruitment of people of color to these studies? And yeah, that's pretty much the context there. Yep.
You know, I think I'll start, you know, because I run many of the clinical programs here. There are some programs where brain donation is required, but the majority of the research programs that we do not have a requirement for brain donation, but it is an optional component. And so we do strongly encourage folks, like our discoveries in hearing loss that could not have been done without the folks that were willing to donate the brain tissue. Always, you know, I always say we never take a piece while you're using it. It's it's after the fact. And there are some, you know, that for religious or other reasons cannot donate tissue after they pass away. But for those of us that are able, this is a gift. It's a gift for our children, for future generations to come, for everyone out there that we know and love, our friends, families, and neighbors. So it is a valuable, valuable, and very precious gift. Think about it. It's not right for everyone, but not being comfortable donating your brain. You heard Pastor Slatter. He has not donated his brain, but he's an active research participant. So, Lisa, did you want to comment on some of the other issues?
Yeah, so the studies that I talked about in Chicago, 2 of them, you have to be a brain donor to be enrolled. And because of that requirement, we have suffered in getting people of color into the study. So when I started my study, I knew that I could not require it. And so I made it an optional component. So I don't think it's a barrier to being in research for people of color. I think there are lots of barriers, but it definitely does not help if you require it. And I think the way that we've been able to get around that in Chicago is through a lot of education, right? So if people understand why you are asking for their brain, they're much more likely to consider it, right? And so we have found that we have to do extensive education with our families of color to really talk about what happened in the past, you know, all the past abuses, how we are different now, what measures we have in place so those kinds of things won't happen, and what scientific discoveries are possible when people donate their brains, and the legacy that they're leaving behind. Like Dr. Jicha said, it's not for them themselves, but it's for their children and their grandchildren. And older African Americans really resonates with them. They want to help their legacy not have to suffer from the disease. So we're one of the few groups that has been able to get donations from African Americans who don't have dementia when they start. We have about 180 brains, you know, in our center from participants. And people, you know, they're starting to really understand the importance, and more people are signing up. But it is true that I think it should be optional for people to make their own decision with their families.
Yeah, I just want to toss in here. So in the UC Davis Alzheimer's Disease Research Center, we have the longitudinal diversity cohort. And so we have about even numbers of white, Black, African American, and Hispanic Latinos. And no one is required to have donate their brain to participate. But we talk about it, as Dr. Barnes was saying, over the course. And what we've learned is that people in these studies develop relationships with the teams and then have trust. And our autopsy rate or brain donation rate is about equal across these 3 groups. And it's because they've come back. And I know in the Sanders Brown, many of you have been here 10 or more times, and you don't have to make the decision the first time you come in. I think Dr. Barnes was making that point. It's actually not a good idea because you don't know what you're getting into that first visit. So, you know, think about it. And if it feels right to you, and I liked what was heard earlier about talk to your family, ask them, say, what do you guys think about this? What do you all think about this? And then make a knowledgeable decision when you're ready. But take your time and make it so that your donation, because it is the most important donation you can give to us who are doing the research. So just to say that this is the way we try to approach it. And it, on average, is about 3 or 4 visits before someone actually makes that decision.
So I'm going to direct these next kind of a combination of questions to Dr. Barnes and Dr. DeCarli. Are there any studies about the effects of pets? Does meditation help? On the Life's Essential 8, which is the most important to control to work on? What's the most easiest to do right away? And then on the purpose of life, could you elaborate a little bit more on those daily activities? Meditation, pets. Essentially.
Yeah, so I'm kind of an anxious guy, so I probably need meditation, but of Life's Essential 8, I can speak to that directly. The 2 things that seem to have the greatest impact is regulation of your blood pressure, your diabetes, cholesterol. So something that you can take a pill to normalize. Mostly the blood pressure and the diabetes. And then the second, which is a part of this, is exercise. Now, I know everyone says exercise, and the first thing that crosses your mind is you're all sweaty and you've been in the gym or done something, no, take a walk, 15 minutes, 4 or 5 times a week, good enough. And so that the amount of exercise is required to help your brain, because one of the things is that when you're sleeping, you're clearing the bad things from your brain, but when you're exercising, you're also clearing bad things from your brain. So modest exercise is good enough. Treating the blood pressure, the cholesterol, diabetes is also, and there are new diabetes drugs coming out now that are just fantastic. And so I think we're looking, medical science is doing some really good stuff right now. And I think they're going to help us move the needle to being closer to the 14 points on the scale instead of 6 or 7.
I was trying to think about the pet question. I feel like I just saw on Good Morning America that there was a study that was that came out about pets being good for Alzheimer's. I don't remember what research study it was. And so it's one study, right? So of course we have to replicate studies. But I think having a pet, I used to be a pet owner, has a lot of benefits, right? I mean, you have a companion, you are probably having to walk the pet. If it's a dog, walk the pet. If it's a cat, I don't know. So having a pet probably is good for your brain, but we need a lot more research to say that. And I know that there are studies now looking at meditation as a potential factor in like sort of these multi-domain studies where they're looking at diet, meditation, and physical exercise all together. So those studies still the results have to come out. And for me, I think anything that's going to calm you and make you more mindful has to be good for your health, right? And it's going to be good for your brain. But we need the data. And the question about purpose in life. So it wasn't activities, it was really an outlook that you have on your life. So if you are a type of person who is really, looking to the future, always thinking about what you want to do in your life, you have goals, you're directed in your life. Those people who are more like that have a better health in general, but also better brain health. But the people who are like, oh, it's never going to work out, my life sucks, those kind of people, they tend to have poor brain health. So it's probably something about your attitude in life, maybe a little bit of personality in there, but it's really about having this positive outlook, always looking to the bright side of things. And we don't know what the biology is yet, but in our observational studies, it does seem to play an effect.
So a little bit of a follow-up question to that regarding the learning, the stimulation, the mode of interaction. Since we kind of live in a world of online and remote working, do you think that kind of shifts the brain health, the online versus the in-person? Do you have any comments on that?
That's a tough one. I mean, the pandemic clearly changed how we interact, right? I mean, I see it across the board in my kids, and everybody. It just really changed how we interact. So I don't know that there's been any studies looking at the effect of like social interaction through media, social media or like the internet or Zoom. But to me, it seems like we really need that heart-to-heart, life-to-life connection with people. And to the extent that you can get that over Zoom, I mean, sometimes that's all you have, right? That's a good thing, but it doesn't replace being able to just look at a person and say, "Hi, Charlie, how you doing?" Those connections are important. But we'll have to just wait to see what because our world has changed, right? We'll have to wait and see what this Zoom connection, this virtual world is doing to us as people. But as much as you can, pick up the phone, call somebody, hear their voice. And if you can visit them, I think that's better than just connecting virtually.
I'll just comment on that because during the pandemic, we actually reached out to folks that were participating in research because we wanted to check in on everybody, number one. But we did ask people about loneliness, about depression, about the impact of the social isolation on that time. We also asked people about their ability because we were concerned. Does everybody have internet capability? Is everybody engaging with family members and friends? And yes, we saw a huge impact on isolation, loneliness, depressive symptoms, and that was lessened in those that had a high use of telephone socialization and or FaceTime on platforms. So at least what we've seen here in the greater Kentucky area is, and we don't know if it's the same as I suspect in person, is probably a greater benefit. But for those that can't get out, staying engaged is what's really important.
Okay, excuse me, we had several questions along the lines of, if I have MCI now, how can I tell what trials I'm eligible for? When will these pending trials, when will anti-amyloid trials come online? Can perhaps an update along those lines? Probably for Greg, I think it's a local person.
So there are always studies that are starting, studies that are stopping, studies that are planned. And there are studies for people with normal memory and thinking. There are studies for people with mild cognitive impairment. There are studies for folks with end-stage dementia for palliative care and quality of life issues. So we try to make sure that we have studies for vascular disease. We try as much as possible to have studies for Lewy body disease. At any given time, there may not be a study that's right. I think Chartorn told us about some brain bleeds in his head. I think we should look at that cerebral amyloid angiopathy study coming up in the future, and maybe a new opportunity will open for him. We'll see how that works, but just get in touch with us at the center. If you call our main number, 859-323-5550, and just tell them I'd like to speak with somebody about what kind of research I can get engaged with, and they will send you back. You'll always get a live person. If you don't get a live person, they're using the restroom. Wait 5 minutes. We do not have an automated phone line. It will not say push 1 for this, 3 for that, or 4 for the other thing. We will help you find ways for you to engage with us.
So there's a couple of drug questions. One about the effect of these newer diabetes, GLP-1s on lowering A1C and diabetes. Is that good for overall health versus dementia? And then a controversy or whether or not the statins, Lipitor and blood cholesterol are actually causative for AD, or does that actually help?
So I can answer both those questions, actually. I will say, just so you know, I'm a consultant to Novo Nordisk, who is the maker of the most common glucagon-like protein agonist, okay? So I may be a little bit biased, but what do we know? What are the facts? The facts are that if you're using this medication to treat your diabetes, your hemoglobin A1C is much, much more likely to be in the normal range on treatment. That's number one. Number two, the likelihood of having a stroke goes down as much as 30%. The likelihood of having a heart attack goes down as much as 30%. The likelihood of having kidney problems related to your diabetes goes down as much as 30%. All of those things are better for your body. Since your brain sits in your body, it's going to be good for your brain. They're testing it for Alzheimer's disease right now. I don't know what the readout for that won't be for another couple of years, but the fact is that it's helping your body, and it's a good drug. So it's got some side effects, and that can make it problematic. But if you can tolerate the medication, it's actually quite a good medication, because what it does is it normalizes, or it creates a normal, what we call homeostasis of insulin in your body. And that's what you really want. You don't need to replace and put more in. What you want to do is normalize how it works. And that's how the medication works. Regarding statins and memory loss, it's a controversial issue. I just will make one point. Older people get memory loss. Older people take statins. When you have two very common things co-occurring, it tends to suggest that they might be one causing the other. And this is where we have to be very careful. And so it's not clear, even though those reports have come out saying that there is a risk. At least the data that I've seen is that if there is a risk, it is pretty small, and the risk of heart disease and other problems related to having an abnormal cholesterol are bigger. I don't know if Greg wants to, Dr. Jicha, you want to?
Yeah, Charlie, I think that was perfect. We are actively engaged in the studies of these new GLP-1 agonists. The Novo Nordisk trials are running at the center. They're close to enrollment right now. We're trying to gather and finish up all the data. But I as well am very excited. They're not medicines for everyone, but they can have powerful effects. And I think all of your comments on statins, Charlie, were quite appropriate. I really have nothing to add.
Well, I just want to say one thing, being the basic scientist of the crew here, is one of the things that we do know about Alzheimer's disease is whenever you have a pathological change, whether it's actually a diabetes diagnosis, cancer, Alzheimer's, it actually fundamentally changes metabolism. It changes your peripheral metabolism. It changes your brain metabolism, because your brain has extra work to do now. It not only has to, think and function and move, but now you're actually fighting something as well. And so a lot of times these anti-diabetes drugs are actually normalizing, or as Dr. DeCarli said, starting to put things back in that homeostatic balance so that you can do things better. And so that's one thing. So nothing happens in our body in isolation. And this is especially true for Alzheimer's disease, where Alzheimer's disease often is not, in isolation in our brain. We have vascular changes. We have other proteins that are aggregating. It's not normally just a singular syndrome. And so one of the things that type 2 diabetes, it's controversial whether it causes more Alzheimer's disease, but what we do know is it does really mess up your vasculature. And so anything that normalizes one of these arms that's negative for something else will confer some degree of risk. And so always think about, especially talking to your doctors. I see this with my parents. is that they'll talk about an isolated thing because they won't think that it's related to something else. And I think when you go to your physicians and there is education there, let them know everything that's happening, because that will actually help you get better care and self-advocate.
Okay, so several people asked about are the slides going to be available, and yes, they are. We will send links where you can download slides. The next question was, there were several questions about recreational, well, alcohol, cannabis, vitamins, 1 or 2 drinks a day. Any comments on those issues?
So we have actually published on, alcohol use using animal models. And the thing with alcohol use is it's really murky. And so in the clinical studies that have been done, it's not good for the brain. It's not good for all-cause dementia. Whether it's related to Alzheimer's is really it's ambiguous at this point. It does, in animal models, it does cause changes within those, amyloid plaques. And maybe some studies suggest neurofibrillary tangles, but the human diseases or the human clinical trials does suggest that it's not good for all-cause dementia. Whether it's of an Alzheimer's type, I think, is still debatable.
I will say that anything in excess is bad, right? That's the most, and as we know, 1 out of 5 people develop an addiction of some type. So abuse of alcohol is not okay. And if you're at risk for that through family history, et cetera, that's something to be mindful of. The WHO has really come out very strongly. I think you probably heard about it in the news that, really all alcohol is bad. I sort of take a more moderate position on that, in that modest amounts of alcohol, particularly while eating, is probably okay. We used to think early on that maybe it was actually good for the brain and the heart by lowering cholesterol, because it does change cholesterol metabolism. In fact, statins do a much better job. So I lost that excuse.
But that's interesting, because in the Chicago Health and Aging Project in Chicago, we did find that moderate alcohol use was actually protective. Moderate.
So we usually say 1 a day. There's some people that say, well, men can have 2, but women can only have 1. I just think that that's horrible. Chauvinist. 1 is good. And no Betty White wine glasses. That's not 1.
All right, we're going to end with this kind of combination of questions. When you're in a study, do you share the participants' findings, especially if you find that something's concerning, like cognitive impairment or amyloid? Does Sanders Brown have support groups or counselors for caregivers? And how do you cope with the stress of the expectation of possible future cognitive decline?
The answer is yes to all of the above. We have very active programs, support groups, educational programs, staff that help manage these issues. The anxiety of, could this be coming for me, is real. It's real for all of us. Anybody who thinks that they are free and clear is a fool. And you're really deluding yourself. Now, if you need that to be happy and less stressed, I'm okay with that. You can adopt that. The first point that was raised in a clinical study, and our motto at the center is, and it is semantics, but I like it, and I make all my team members practice it. We do not have research participants. I do not like the word research participants, because research comes before the person. I don't like that. Instead, we have people that are helping with experimental studies, or people that are taking experimental medicines. The person comes first. If we find anything that has a clinical bearing in a clinical trial by federal and international standards, we must not only notify you, but we must help you to arrange appropriate care for that condition. So we will be very proactive. I will tell you, we find very few things in our thousands of participants across hundreds of studies over the years that are actually related to the study itself. It is much more common for us to find in a routine blood draw that somebody's starting to develop too many white cells, and it may be a sign of an early leukemia. That we do an EKG and we find atrial fibrillation and abnormal heart rhythm that they didn't know about previously, that we find that their kidney function is beginning to drop. And at the minute that we see that, I always tell everybody, you become the second to know. Why? Because I'm the first to know. And the next person I'm going to talk to about it is you. And then we're going to come up with a plan together of, do we need to address this? If so, can I best help you address that? So you are always covered. You will never be a research participant. You will be a person that we care for in the context of research, whether you're taking an experimental medicine or whether you're in a study without an experimental medicine. That's our motto, that's our policy, that's how I and all of our staff live every day. So, and if anybody has an experience otherwise, please let me know. That's one of the reasons why Mrs. Bailey talked about the participant advisory group. We are always looking. Are we as good as we think we are? There's always room to improve, but when it comes to care, I don't think that we're second to anyone. This is always the most important thing, and I'm sure that Lisa and Charlie, Dr. DeCarli and Barnes might want to comment on that, because I would bet they have the exact same policies and principles at their institutions.
I was just, as you were talking, I was just thinking that this is why Kentucky's number one, this approach, because you all are people and you are the most important thing for us to understand Alzheimer's. And if more researchers had that type of, idea about people in their studies, we'd have people breaking down the door to be in our research studies, right? So it's a process. I'm not going to say everyone in the Alzheimer's field thinks like Dr. Jicha, but that is exactly how you should be treated. And that's Dr. DeCarli and I run our studies like that, of course, but that's why Kentucky's number one. So you should be very proud.
And I just want to add one other thing too, and that is knowledge is power. Okay, knowledge is power. So if you're joining a study because you are worried, that's the best thing you can do, because we will tell you, we'll talk to you, we'll help you, we'll educate, and you can make knowledgeable decisions and you can have power over your own health. And that's the best thing you can do for yourself. So, keep coming back. Okay, thanks.
And with that, we'd like to thank our panelists, Dr. DeCarli, Dr. Barnes, Dr. Macauley, and Dr. Jicha for answering our questions.
So Dr. Van Illich will come up to do a wrap up, but I'd like to ask our panelists to stay here. And so if we got to as many questions as we could, but if you do have questions, our panelists will stay as long as they can to try to address your questions. So if they'll stay here, Dr. Van Illich can finish up.
All right, and thank you, wonderful moderators, for moderating our session as well. So I just wanted to wrap up by saying thank you. Thank you guys for coming here. It was above and beyond, especially under today's conditions. So, and probably you may have to walk a little further wherever you had to park. I'm sorry for that, but I think we've had a great symposium. I also just want to please put your evaluations down. You can leave them on the tables. We'll pick them up later, but please fill out your evaluation. That helps us a lot to know what we're doing right, what we can do better, and what you'd like to see next year for our 15th annual Markesbery Symposium. So thank you all and good luck getting home.
Is this still on? You know, a little bit of rainwater with that physical activity on the way out to your car doubles the benefit, I've heard.